Second day, post-lunch session of the Science in the City, part of the Hyderabad Literary Festival. All right, so Science in the City, Sci City Hyderabad is part of an initiative, an informal initiative that Somnath Karak, who heads science communications at CCMB, and me, Teja, who has a similar role at LD Prasad, the Institute, have put together. This afternoon session is pretty interesting. Right, we are asking a very interesting question on superbugs and their, and as a society, are we doing enough to address the science around it and also, the problem of superbugs? How do we understand them? We have two speakers and a panelist and a moderator. Sorry, we have Dr. Soumya Swaminathan, who was WHO's first chief scientist, and before that, she was the deputy director general for programs there. She's a global leader for her work with tuberculosis and HIV. The second speaker is Nandita, Venkatesan. She's an extraordinary advocate for efforts to address AMR. Nandita is a journalist and a public health advocate. She's had a dramatic and a prolonged fight with tuberculosis, which left her with the after effects of its treatment. And Nandita now urges for patient-centered care. Sara is an independent researcher, practitioner, and trainer who champions creative and participatory approaches to connect science with society. She is a co-founder of Superheroes Against Superbugs and has developed and contributed to many innovative projects that blend science, policy, arts, and the community. Sara, over to you.
Thank you so much, Teja, Somdatta, and HLF. I would like to invite my panelists on the stage as well. I hope you had a good lunch and are ready for this post-lunch session. Hope we'll keep you awake, and if not us, then at least the heat here will. It's an absolute pleasure to welcome you to this very important session, and it's particularly special for us at Superheroes Against Superbugs because about 7 years ago in Hyderabad, we had hosted the first public discussion on AMR, perhaps first for the city, and in fact, some of the members at that discussion had asked us that if you are saying this is such an urgent public health issue, then why is that we don't read about it, we don't hear about it, and why are there no efforts to raise awareness? And that's really, was the genesis of our very humble, small initiative, Superheroes Against Superbugs, where we try to find places, opportunities to talk about AMR to those who have, never heard of it. And of course, since then, there have been a lot more awareness, a lot more discussion in policy and media spaces about antimicrobial resistance and superbugs. And I think COVID-19 also provided a very important wake-up call. It also made us realize just how ill-prepared we are for infectious disease outbreaks. As a society, as health systems, it also brought out very deep inequalities in social and health systems in our country. And so just imagine if there are infections that cannot be treated by the drugs that have been designed to kill them, then the sort of pandemic that would bring about. And that's the theme and the topic of this discussion. I also realized that antimicrobial resistance, what we call in science and health circles, to describe these untreatable infections or hard to treat infections, which could be caused by viruses, bacteria, or fungus, other parasites. What happens when you're unable to treat them? And we use a very technical term called antimicrobial resistance, or AMR, to describe that. AMR is also a very Hydra-headed problem. It has a lot of different elements and aspects, all of which we might not be able to efficiently cover in the next 50 minutes. But I have two really fantastic speakers with me who will try to help us unpack as much as possible over the next 50 minutes or so. And hopefully by the end of this session, you will leave with some, information and also some inspiration to act, in your own individual capacity. And Teja has already introduced our speakers, so I won't be doing that again. But suffice to say that, I'm both Soumya and Nandita are the reasons that we all feel safe. We know that they are going to speak up for us, speak up for health, and will keep us safe. So Soumya, I think before we move into some heavier stuff on AMR, I would like to request you to maybe start with some basics. Imagine you're explaining AMR to someone who's never heard of it. What is AMR and why should it matter to the audience here?
Hello? Hello, can you hear me?
Not very well.
Take the other mic. Yeah, thank you very much, Sarah. Lovely to be here. Very energizing ambience and atmosphere with so many young people. It's really nice. So yes, how do you, I totally understand that using the word antimicrobial resistance or AMR, probably nobody's going to read further. You're going to just put people off because you can't make out what it is. So that may be part of the problem here, where we don't get any attention to this. Drug resistance, I think people understand a bit better. But if we were to explain to school students, when I was working on HIV and I had to explain to children who were infected what was happening to them, I used to tell them that their white blood cells are like an army that fight infection. And in a healthy body, the white blood cells can actually overcome the infection. But what HIV, the virus, does is that it kills your soldiers. And so your army is very weak and depleted. So the next time there's an infection, the army is unable to fight the enemy, and then you get repeated infections. So I think we'll have to think of similes like that. Perhaps, the bacteria as some kind of a monster or something that's coming to get you, or a fungus or a virus, as you said. And by giving it small doses of something, you make it accustomed to it. So it almost becomes like it's food. It no longer looks upon that as a toxic chemical that's going to kill it. Its body gets used to it. It's able to withstand that antibiotic because it's seen small. That's what happens when we have soil contamination with antimicrobials, that the bacteria see small quantities, or if you don't take your antibiotics in the proper dose or for the proper duration, then what you're doing is you're showing a little bit of the antibiotic to the bacteria, not enough to kill it, but enough to convert it to become resistant. And so that is one method by which organisms become resistant, and then we call them, antibacterial or antimicrobial resistance. Yeah.
Yes, thank you so much for that. Am I audible? Is working? Okay, so thank you for that very simple definition of AMR and how bugs become superbugs, and they become harder to treat by antibiotics in case of bacterial infections. And so I think beyond the medical and scientific jargon of how we would explain AMR, as someone who has dealt with not one but two bouts of tuberculosis, and tuberculosis which was also resistant to drugs, how would you explain AMR to someone? And I should also mention here before you go, which we missed in the introduction, is that Nandita was instrumental in overturning and stopping the patent that the pharma giant Johnson & Johnson had filed in India for bedaquiline, which is one of the most important life-saving medicines, antibiotics for tuberculosis, especially adolescent tuberculosis. And Nandita was part of the team that fought against it and won the case, making this life-saving drug accessible to a large population in our country. So I think really kudos to these efforts. And over to you now.
Thank you, Sarah. Firstly, one question to the audience. How many of you have heard about TB, malaria, cholera? Oh wow, that's really good to know, because in circles that I've gone, either I've been told that oh really TB is still around even now, and I thought only my grandparents had it or my parents had it. So it's very welcoming. I've had even teachers tell me right on my face, teachers who have taught me that I think I remember only my grandmother had it. So then and I would say that look, I had TB myself. So it's not it's not a non-existent disease anymore. So it is very much around, and all of these diseases that I mentioned. So it's glad to know that the audience is aware about the fact that these diseases still exist. So yes, so I did have TB twice, and I dealt with it at quite a young age. And I was 17 years old when I had first started undergraduate studies. I had started college in Mumbai, and I had contracted TB in the intestine, and that itself was something that was very new to everyone, including me, because TB is seen as a disease that you generally get in your lungs and not something that you get in the intestine of all the places. So I got it in the intestine, and back then the treatment durations were very long. So I had taken medicines for 15 months. Thankfully, today we have medications where when you get a simple form of TB, you can be cured within 6 to 9 months. But back then, when I had got it in 2007, I took medications for nearly 15 to 18 months. So it was technically my first year and my second year of college. That I went with dealing with this disease. And then after that, I was completely cured. I went on to do a master's, for which I had shifted to Delhi. And then I had started to do I had started developing interest in finance, and I thought, okay, I would maybe become a financial planner. And if not for what would happen after that, I would probably be sitting at some financial company analyzing mutual funds and giving out advice to people on how to invest in the markets. But after that, of course, but I can't think of anything else today apart from talking about health and AMR. It feels ages ago that I thought I would be doing financial planning at some point. But yes, after that, I finished my post-graduation, and then I was diagnosed with TB again. This time around, I was told that it was a very severe form of the disease, again in the intestine, again in the same place where I had gotten the first time, despite being cured fully the first time around. And again, I was 23 years old, about 5-6 months short of turning 24. And yes, so I was told that, that you continue with your medications, we'll have to restart your medications, and then you'll be fine, don't worry about it. Of course, things didn't turn out that way. I was hospitalized for a very long time, for nearly 90 days.
Does that also mean that each of these regulatory...
And I also had to take a battery of toxic medications that were administered to me one after the other, with the simple aim that my life should be saved. I also underwent 6 surgeries in my abdomen, repercussions of which I face for several years after that. It takes a lot of time to come to terms with this kind of overwhelming situation where your life is turned upside down completely. And then I also ultimately ended up losing my hearing because of one injection that I was administered as part of my TB treatment, which is called as kanamycin. It was considered, I remember, of course, we were warned about all of the other side effects except for this one side effect, which is what I ended up with, and that was the loss of hearing. We were told, the doctor told us beforehand that, look, we have to administer kanamycin. You may face problems with your kidney, you will face rashes, may face problems with your liver, but one thing that they didn't tell us about was the loss of hearing, and that is what I ended up with. I remember I had a very small nap in the afternoon, about 2 days after I turned 24. I slept for about 15-20 minutes, and I woke up, and then I could not hear anything. That's all. So it was that quick, that an afternoon nap is all it took for me to lose my hearing because of some medication that was given to me a few days back. So it was of course, it was difficult. And after that, of course, when I used to go and meet people, when I thought that I should, when I wanted to understand what was exactly happening with me, and why did I have to go through what I went through, I would often go and speak to people and find out. And the first thing they would tell me is, you lost your hearing because of TB. How come we have never heard of it? We never even knew the fact that TB can cause was hearing loss. So there was a lot of, I felt, ignorance about it, even at very higher levels, when I would go and talk to possibly people within the government or even among medical professionals. In fact, they would be very surprised to know that I lost my hearing not because of some problem. Say, for example, the most common perception is that if your mother has faced problems in pregnancy, then you lose your hearing at birth. But that was not the case. It was bang in the middle of my life. So I think AMR and TB, and it's all very intricately linked. And to put it simply, the fact is that imagine that you've been told, okay, you have this XYZ disease, and then you start taking medicines, but you don't know whether it is going to work or it is not going to work. So imagine you're staring at that, especially when you are at a side where you may not really have knowledge of what you're dealing with. So you don't know whether the medicines that you're taking are exactly going to cure you or they are not going to cure you. So it's a very dangerous proposition, to be honest. So I think, and AMR is something that happens with a lot of the infectious diseases, not just TB, it's cholera, it's malaria. If I'm not wrong, there were even drug-resistant versions that came up during COVID. So I think it's a very serious issue.
Thank you so much. And every time I listen to you, Nandita, I'm reminded of that, AMR is not just about the science and the health and the data and the facts and the figures, but there are actually people who are dealing with the consequences of AMR. And I also want to at the same time acknowledge that, antibiotics, which are a type of antimicrobials, have been life-saving. When they were discovered by Alexander Fleming more than 80 years ago, they were the miracle drugs that we needed, to save people from very simple infections. And interestingly, Alexander Fleming, when he received his Nobel Prize in 1945 for discovering penicillin, the antibiotic, he, in his Nobel speech, warned everybody that, antibiotics are great, but overusing them or misusing them can result in bacterial infections becoming resistant to their effects. So it was actually something that we've known for a very long time. But if you look at the data from the 20th century, antibiotics have greatly reduced deaths caused by infections. But we're now seeing a resurgence of infections that we are unable to treat, and that's where AMR comes into the picture. So, Soumya, we also know that India has the highest burden of TB in the world. And there are many other factors because of which India is being called a hotspot for AMR. So could you maybe talk to us a bit about what are the vulnerabilities or what are the gaps or the issues that we are seeing here in India because of which AMR is becoming so serious?
Sure. Just to add to your previous point you were making, that in 1971 or 72, this US Surgeon General announced, saying that we have won the war on infectious diseases. Because at that time there were so many antibiotics that had been discovered that human beings thought that that's it. We no longer need to fear infectious diseases, and of course, boy, were we wrong. They've definitely got the better of us. So India, of course, is firstly, because of its large population size, any problem we talk about is huge in terms of the magnitude, in terms of the numbers that get affected. TB, we've been, number one for a long, long time. We have about a quarter of the world's burden of TB and more than a quarter of the world's TB deaths. But we're 17% of the world's population, so we actually do have a disproportionate burden of TB. The main risk factor for TB in India is undernutrition. So there have been many, many studies that have shown that. The others are things like, of course, smoking, including air pollution that weakens your lungs. Diabetes is an increasing risk factor now, alcoholism, and then conditions like HIV, AIDS, or if you're on immunosuppressive drugs for cancer treatment or something, then your immune system is very weak. But that's the same thing that nutrition does to your immune system. If you're malnourished, your immune system is extremely weak, and therefore you're susceptible to TB. Now, one thing about TB is, though it's such a age-old disease, it's been with humankind for thousands of years. It's been found in Egyptian mummies, in the bones. There's evidence of tuberculosis. So it's kind of evolved with humans. There are different species in animals as well. So a lot of mammals have TB. So you'll hear sometimes of the tiger getting TB or giving it to, or the elephant giving it to the, So it can spread between animals and humans as well. And the thing is, after thousands of years, we don't still know exactly how our immune system controls TB. That is the main reason why we don't have a vaccine for it, why we're not able to really get on top of it. Unlike some of the viral infections for which we have very good vaccines, including COVID, measles, hepatitis, we could immediately understand that if you have this many antibodies in your blood, you can actually overcome the virus. So you just have to dose your vaccine to get you that level of antibodies in the blood. But TB is not controlled by antibodies. It's controlled by something called our T cells. These are white blood cells. And we don't know exactly how. And we don't know what kind of vaccine will stimulate those T cells. So there's a lot of research that still needs to be done. The other thing we don't really understand about TB still fully is how it spreads. So the last survey that was done in India, it was called the National Prevalence Survey, where you go and sample people. You ask them randomly, you pick up people, go to their homes, ask them if they have any symptoms. But even if they don't, you still do an X-ray, a chest X-ray, and then you collect some sputum for testing. And that's how you find out how much TB there is in the community. So that's the prevalence. And it was high. This was done in 2020-21. And we had about 300 per 100,000 people, with active TB, where you can culture the bacteria. So they're infectious. But the surprising thing was that about half of them had no symptoms. So when they had been queried, do you have a cough, do you have a fever, have you lost weight, are you feeling tired? They said no. So either they had very minimal symptoms or no symptoms, and yet the cultures were positive, which means that they were capable of spreading TB. And so these are called asymptomatic, like we had in COVID, right? A lot of people who had COVID but had no symptoms, and that's why COVID kept spreading, even though you were quarantining people and isolating them. So this asymptomatic transmission of TB is going to be a challenge actually for elimination. And then, as Nandita, beautifully explained, over a period of time, every antibiotics that's been discovered, by the way, till now, starting with Alexander Fleming, bacteria become resistant to it. It's just a fact. That's how bacteria are, surviving for such a long time. So no antibiotic lasts forever if you don't use it properly. For TB, it was discovered long ago in the 50s that you had to use combination of drugs. That if you gave one drug, the patient would respond. So these were early studies done in Edinburgh by a very famous doctor, Sir John Crofton. The first one to treat TB meningitis. And he was so delighted because he used streptomycin, the same class of drug that caused your deafness. And the patients dramatically responded. In 2 months, people with meningitis were recovering, and then it was back to being sick again in a month. What had happened? The bacterium had developed resistance to streptomycin and then started multiplying and growing again. So 2-drug therapy, 3 drugs, 4 drugs became the standard of care for TB. Now it's very difficult, those of you who've had TB treatment or even a simple course of antibiotics, to take it for the whole 7 days. How many of you complete your antibiotics properly? 1 dose in the morning, 1 dose in the afternoon, 1 in the evening for 7 days. How many people complete a dose like that without missing a single dose? Okay, 1 or 2, wonderful people in the audience. They're superhuman, or they use some way to remind themselves. Well, a lot of people with TB, for many reasons, including economic reasons, they have to go to work, there are many other pressing problems, the daily wage labor. maybe the drugs make you tired. And some of patients have told me on an empty stomach, we cannot take these drugs. So if you're hungry in the morning, there's no food in the house, you will not take your drugs. You would rather go out, work and earn, to put some food on the table. So we can't blame people always for not taking the medicine. But also after a month or two, you start feeling much better. And the tendency is to say, I must be fine now. Why this unnecessary long course of treatment? Some people may stop because of that. Anyway, for many of these reasons, or you forget one day or you forget 2 days. So that's how the bacteria actually becomes resistant. So a long time ago, I remember I was a pediatrician. I am a pediatrician in Chennai. We did one of the first surveys in children looking at drug-resistant TB. And we found the same rates of resistance as in adults. Nobody believed us. Everything must be wrong. Your study was wrong. Your lab was wrong. But the fact is, children get the disease from adults. And once adults are going around with drug-resistant bacteria, children are going to get it. So we can't... The tendency of the medical profession sometimes is to blame the patient, or quite often is to put the blame on the patient. And we have to stop doing that, because it is not the patient's fault. She didn't do anything wrong, she perfectly took her full course of medicines, got cured. The second time, just bad luck, she got a drug-resistant bacterial infection. By the way, I must tell you, in 2018, when I was at the UN, from the WHO, I was there was a very high-level meeting on TB. It was a global-level meeting. Nandita was the patient survivor who spoke there. There's usually one person who gets a chance to speak. So she was selected to represent the whole world. And at that time, she was deaf. And she spoke without being able to hear anything. The whole room stood up. It was all heads of state and everybody to applaud her. And she ended by saying, I can't hear you, but I hope you can hear me and get the message that we need safer drugs for TB. So the power of personal stories and advocacy, we were talking about that earlier today. Any amount of data and things like that. I know of young newborn babies who die because their bacteria are resistant to drugs. Imagine a newborn child dying because we can't cure their infection. 50,000 babies, by the way, die of neonatal sepsis in India because of drug-resistant infections, which they get from their environment. So I think the awareness on this is extremely low. Things like pandemics catch people's attention because it's a very sudden and, it's there in your face. This is a slow-moving pandemic or a slow-moving crisis. And only those who experience it or the family members, you realize what a serious problem it is. But it's growing. And so this is why it's so good that you have this Superbugs program, that you're educating people, that you're creating awareness, and there are ways in which to reduce it. It's not something we don't have a solution for.
Thank you so much, Soumya. That was incredibly helpful and also very expansive overview of why MR is such a problem in India. There's so many. It's such a, I hate to use this word, but such a multifaceted problem. Nandita, would you like to add something based on your experience of, seeking treatment? And what do you think, what were the gaps in the health system and also society at large?
I'll come to mine as well, but I think taking up from where ma'am said, a big problem right now is that this whole demand-supply mismatch that we're seeing in terms of antibiotics, in terms of researching for new antibiotics. I remember that when I had the data for August 2023, if you see the last data available for clinical trials, I think only about 2% of the clinical trials, or even less than that, is for bacterial infections right now. Out of the entire share of clinical trials that are happening, almost 2% or less than that is for bacterial infections. So I think that just shows to me that how possibly people, like they said, that I think people thought that it's done and it's got forgotten and it's done. We are done with it in the 70s and 80s. Now we should move on. We should do other things. But like, no bacteria or virus ever leaves us, and I think COVID showed us what is the scale of devastation that can happen because of any infectious disease. And we also saw that when something hits us so suddenly, we also saw the scale of action that just went about. People moved so swiftly that I was amazed, because for years before that, a lot of us have been screaming our lungs out and saying, you have to do something. You have to do something about not just TB, but about about infectious diseases as a whole. And there is AMR, there's so many other dimensions that are there that have to be addressed. But you saw that, right? One COVID, and people just swung into action. And thankfully, yes, I'm glad they did. But yes, because of the fact that people finally saw that what is the scale of devastation that an unknown virus or an unknown bacteria can really cause. And it can really shut down economies. And it's very common today because even when I do data analysis as part of my work, we analyze every data today in terms of pre-COVID and post-COVID. Everything from every data, from analyzing economy related data to any data related to health outcomes, everything, you will see that there's a downward spiral. If you have to make a chart or if to plot the data in a chart, you will see one downward spiral that hits right at the bottom in the x-axis for COVID for 2020, 2021, and then suddenly there's a spike after that, or that it's a very slow moving process to the top. So it's really, we can see the fact that a lot of people swung into action in terms of getting the vaccines out, in terms of getting the drugs out. But we need to show that sense of urgency for everything. We need to take lessons from what happened in those 2 years and not really forget those 2 years and start building upon those lessons for the way forward.
Absolutely. I think with that momentum that infection, disease and outbreak preparedness has got because of COVID, I think we need to maintain that. Soumya, we often talk about AMR. We've been talking about AMR in the sort of clinical, hospital, human settings. But we're also finding antibiotic residues, superbugs in the environment. In fact, India is being called the pharmacy of the world. We're sitting in a city which has a lot of pharmaceutical companies. In fact, there have been many studies that have shown that lakes in Hyderabad have got antibiotic residues and superbugs. So can you also talk about these sort of invisible links that are there that we are not able to maybe see right now, factors that are there that are contributing to AMR?
Yeah, so the most obvious one is human beings and what we do, our behavior with taking antibiotics. We just go purchase them over the counter. The pharmacist also sells them over the counter. And in fact, we'll give advice also. When I go to pharmacies, I just try and overhear what he's advising other people, And I've even heard them saying, take this rifampicin for 2 days for a common cold. Rifampicin is one of the main drugs for TB. So even though we have Schedule H and Schedule everything, which actually limits what drugs you can and cannot sell without a prescription, in our country, those are not very well followed. So I think the fault lies with people who want medicines for everything, in fact, preferably injections. Still in our country, people think you are not a good doctor unless you're giving an injection, So we have to educate people that for a viral infection, you don't need. And during COVID, so much antibiotic was used unnecessarily that the rates of AMR have actually gone up after COVID. So I think one is in the whole medical structure, infrastructure, whether it's unqualified people, doctor, so-called quacks, or nursing homes or hospitals where higher and higher level antibiotics are used, or it's pharmacists and people self-prescribing, or the neighbor telling you, why don't you take 2 days of this, you'll feel much better, I did. That kind of thing we have to stop, and we have to get very strict about prescriptions. Then you have the entire other areas, environment, how antibiotics are getting into our environment. That's where the agriculture, livestock and fisheries sector comes in, aquaculture, poultry farming. And this is not only in India, it's all over the world. People use a little bit of antibiotic in the feed because they think it will act as a preventive for infection. So to keep, because they're otherwise so unhygienically being kept. If you had a hygienic farm, why would you want to give antibiotics? But you've stuffed so many animals into one place that it's extremely toxic environment for the animal, and they're highly stressed and likely to pick up infection and spread it. You see how H5N1 is spreading in the US cattle farms now. And they don't really seem to be that. It's just one more mutation and it's into human-to-human transmission, and the next pandemic will begin. So we're much closer to the next pandemic than we think anyway, but that's viral. This is bacterial. So using these small doses of antibiotics for chicken feed, aquaculture, and farmers may not even know that it's mixed, frankly. They may not be doing it on purpose, but I know that in large farms in the US, for example, they do it on purpose. Because I've had arguments with very senior government people in the US when I was in WHO, saying our guidelines clearly say you shouldn't use antibiotics as growth promoters. And they have fought back, saying we will, because that is how we do our farming. And WHO or anyone else not going to change the way we do things. So, if that's the attitude, then someone else is going to pay the price. So the bacteria in the soil and the environment, they get exposed to these small dose of antibiotics and become resistant. And that's how you can then, that then of course spreads. Then the water bodies, again, the discharge from hospitals, from industry, pharma industry, we know that a lot of that discharge contains very harmful substances, including antibiotics, other chemicals, and so on. So if you do environmental surveillance, which is now possible to do, and again, COVID was gave a good fillip to environmental surveillance, where you collect wastewater and you can use these genomic technologies to look at what's there in the water. So you can use it for polio, you can use it for COVID, you can use it for many other things, including antibiotic resistance. I think that all cities must implement this and make the data publicly available so that the public also knows what's the prevalence of antibiotic resistance in the environment. And I think all hospitals should be made to put their data transparently on their websites. That's also a good incentive, right? If you want to look good, then you must not show high rates of AMR, and it's what's called nosocomial AMR, which is infections acquired in hospital, drug resistance acquired in hospital because of the bad policies that are used. So every hospital is supposed to have an infection control committee and a policy and a nurse or a doctor who's responsible for antibiotic stewardship. But we must make data, ask them all to put out their data, and that's another way of creating a healthy competition to do better. Similarly, industries, I think our environmental regulations are very lax. So we're really not testing or taking action against people who are putting all sorts of harmful chemicals out into the environment.
Thank you, Soumya. And so what have been some crucial developments in this area in the last couple of years that you think are quite encouraging, quite promising in tackling AMR globally, and also any good examples that you've seen in India or otherwise?
Yes. So I think we must talk about the silver lining as well, because all of this is bad, and there is a lot of behavior change that's needed. But on the science side, there's a lot of innovation happening, a lot of new, I won't say a lot of new drug development, because unfortunately it's not something that companies make a lot of money out of. So most big companies have gone out of antibiotic development, the Pfizers and the Glaxos, and none of them are doing any R&D anymore. Even Johnson & Johnson that made bedaquiline, the drug that is almost a miracle for MDR TB, they've shut down their global health program. So they don't see the profit in it. So they'd rather get into drugs which can sell a lot and make profit. TB is a disease essentially of poor countries. So it's not going to be a money spinner. And this is the same reason why we don't see vaccine development for TB. So, but the hope is countries like India, and I think the BRICS countries, we have a lot of capacity for innovation. There is a lot of innovation happening, a lot of new molecules that are being developed, especially by young scientists in labs all around the country. But the problem is it's a long pathway from that initial discovery to become a drug and get into the market. You need a lot of funding, a lot of players, a lot of collaboration. You need animal studies, you need phase 1 human studies. So the government is investing in these facilities now. And Hyderabad is a good example, I think, of many of these kind of facilities coming together in one place. And you see a lot of R&D innovation happening. So I think that there is definitely hope, but the hope will come from countries like India. We cannot sit and wait for the high-income countries to develop a drug and give it to us. That is not going to happen, whether it's TB or whether it's other infections.
Absolutely. And I remember Nandita and I, when we had our last chat, Nandita had said that as soon as the West or the global North got rid of TB, they thought TB was gone. And they stopped, looking for cures or treatments or prevention methods for TB. So would you like to weigh in on that?
Yeah, I think ma'am was very correct. And we saw that, again, I go back to recent memories, of course, COVID, a lot of us have. We saw the kind of, what we say in Hindi, Mara Mari, literally the fight for vaccines that we saw among countries, pouncing on each other. And it was like a race to the bottom, I felt. So this whole concept of what we say as global health and global health solidarity, I think all of that, I just felt came apart when we saw the kind of fight that was going on to get the vaccines, and we saw that there were several countries who got access to the vaccines very late. Thankfully, we were not one of them, and we did manage to vaccinate a large proportions of our population, but a lot of African countries, for example, didn't get the vaccines or got it very late, and there was such a limited supply of vaccines initially, especially the mRNA vaccines made by Pfizer and Moderna. And I remember I was in the UK at that time. I had gone to do a master's in Oxford, and it was right in the middle of the pandemic. And I remember I had gotten vaccinated with the Moderna vaccine from the UK NHS. And I remember my first thought was that, okay, I have got the vaccination, but I knew that my parents and my brother back home were not vaccinated at that point. So it was, the difference was very stark. Almost a year within the COVID outbreak, all of us in the UK, whoever was there, we had all gotten access to this mRNA vaccines, and I had even gotten the second shot of the Pfizer vaccine and the Moderna vaccine. But it took at least a few months after that until my parents and my brother got vaccinated here. So that difference is there, that I think India now needs to really think for itself. And I think even in the TB program, I saw a very positive development for several years. I think India was very highly dependent on US funding. The government a big proportion of the TB budget, the public budget, was very reliant on USAID funding. But thankfully, the government has stepped up funding, and we can see that if you look at the share, thankfully, government's own share in TB funding has gone up in the past 5, 6, 7 years, and I think that's a very positive development, especially when we are seeing how this whole global health solidarity is panning out. It is important that we ourselves do things to strengthen ourselves, especially for these diseases, when you know that others are not going to help us after a point. So TB that way I saw a very positive development. After years of US relying on US funding, we are stepping up our own funding. And I think, if I'm not wrong, recently, about 6 months back, 5 to 6 months back, the government had brought out first antibiotic for AMR that treated a wide range of infections. So I think some of these developments are very positive. But one point that I would like to add here, just the last point, is that I think all of this ultimately ties out to how we invest in health as a whole. And I think there is a long way to go, because India's public investment in health still remains quite low. It's growing, but even if I see the data, for example, if I was looking at the data recently before I came here, so the central government's own funding on the health ministry as a total percentage of the total expenditure in the budget, it has unfortunately gone down in the past 2 years. It was almost about 3% before the pandemic, but after pandemic, it's almost being flattened at 2% or something. So I think we need to start, it's all like, it's a lot of mixed signals. So we need to improve and bump up our investment in health, only because of the fact that we can't be relying on anyone else anymore.
Absolutely. Thank you for saying that. And I have a few more questions, but I also realize that we don't have much time left. So maybe we can take a few questions from the audience. Can we get a mic there?
Hello. Yeah, what a thrill it is to hear from this panel. I just wanted to ask, ma'am. So totally agree with you on the overconsumption, and like except for Schedule X, I don't think there's hardly any restriction on where and when you can buy any other scheduled drugs. But how much of onus is on our medical practitioners? Because as like some of the health economists in their research suggest, apart from the rural and the semi-rural India, it is all 3 minutes, 3 questions, and 3 medications, and one of them is an antimicrobial, right? And so, is it the problem in the training, or is it the problem of doctors playing to the gallery and reassuring the patient that, you know what, if I don't give him or her a microbial prescription, they won't.
You'll have to keep the question really short because we need
they
to
won't be confident. Or is it the cutting edge research on AMR and the dangers of the epidemic not going into practice and not translating into the clinics?
Thank you.
So I think he's asking about the responsibility of the physician or the care provider here. So one of the problems here is that, we've lagged behind in research on diagnostics. So if you really go to a clinic, the doctor, if they order diagnostic tests, it's going to cost a lot to do microbiological tests, and it may not even be available in many rural areas. And this may be one reason why doctors will just have to do some guesswork almost as to what you may be suffering from and give. So in that process, definitely there's some overprescription of antibiotics. So the key point here is that we need to invest in diagnostics. And again, after COVID, we have many now very good platforms where you can have, even at a primary health care center level, we should be able to test, even these rapid tests. So that's one. But responsibility has to be shared by all, by the pharmacist, by the regulators and the government for not taking action, and by the people who are prescribing and the people who are demanding. Because the consumer also should be enough health literate to ask, what is each drug you're giving me and for what is it? We don't ask, right? We just take all the drugs and then without knowing what we are consuming. So a lot of health literacy is also needed.
Thank you.
Yeah. One quick point to Nandita. Congratulations, actually, but surprises me that you were in Oxford, but you took a Pfizer vaccine. I don't know whether it's to do with better marketing by Pfizer or but more importantly, I just want. Hello, I don't think the audio. I think it's quite audible. So, Nandita, first, just wanted to briefly tell that it's good that in Oxford you were there, but you took Pfizer vaccine. Maybe it's because of marketing by Pfizer. I don't know what's the reason. But anyway, congratulations on your incredible journey. Doctor, to you, the point was actually you mentioned that we are closer to another pandemic. Can you just explain that, lest it be wrongly understood that we are, that is always the danger. So if you can just elaborate a bit on that. And the footnote to that is when you Google TB in Indian context is 1 death every 3 minutes. Despite that, Googleable, but still, why is it that we're not having that pandemic-like scare?
So your last question is a very good one. I have no answer for it as to why we don't do more for TB, despite the fact it kills so many Indians. It's the #1 infectious disease killer in India. So let's debate on that maybe later. Yes, pandemic, I should clarify because I don't want headlines tomorrow to say that, I've said that the next pandemic is around the corner and then everybody starts panicking. So thank you for clarifying that. The point is that there are so many these viruses in animals currently circulating that we are not even aware of. Some we know, some we don't know. Influenza is one that we know a lot about because we are doing surveillance. There's a global system. Of course, now the US pulls out of that. I don't know what's going to happen because then that global system will get disrupted. People won't be sharing data anymore. That was the whole idea of setting up. It's 50 years old, the global influenza surveillance system. But there are so many other classes of viruses. We are not doing regular surveillance. So the One Health mission in India now will start doing that. But what I was saying is we have to be prepared because it's a question of time, really, the mutations that the virus develops. One more critical mutation in that H5N1, and it will develop a human-to-human transmission potential. Right now, it can't. It's going from the cow to the human. That human cannot spread it to the next human. The moment that is, and virus will keep trying to do that. So one of these days, a virus will do that. Then it will start spreading. Then it all depends on whether it's a mild one like H1N1 in 2009. It didn't cause much of a problem, even though it was called a pandemic. Or it's a very serious one like H5N1, which has a 60% fatality rate. So I think we have to be prepared in all ways. We have to be prepared by doing research, both on how these things spread and where we are now. We have to share data with other countries and with our own states. And we have to prepare the vaccines. The prototype vaccines must be ready, so that the moment there's a new virus out there, you have the genome sequence today within hours. And it can be quickly plugged into especially with the mRNA platform, a vaccine can be created in a few days, really. Of course, then it has to go through testing. That will take a few weeks. But the goal is that next time, within 100 days, we will have a vaccine as well as a diagnostic drug. I'm not so sure because antiviral drug research has not been very successful.
Thank you. One final question, yeah.
Soumya ji, is there any logic to the anti-vaxxers? So is there any logic to what the anti-vaxxers? Because every day over the last 3 years, I keep meeting people who said that they didn't take the vaccination and they seem to be doing fine. They got COVID and their COVID was as bad or as good or as long lasting as my COVID after having taken the vaccine. So is there any logic to the anti-vaxxers?
Yes, I get a lot of that as well. The problem is the people who didn't take the vaccine and died are unfortunately not here to say that, I died. But the data is very, very clear. There is absolutely no doubt that the vaccination was more than 90% protective against severe disease and even higher against death, more than 95% protective against death. In the US, the data shows that the red states, the Republican states, had much higher death rates due to COVID than the Democratic states. It was only because of vaccine hesitancy that was fueled by, and I really don't understand what these anti-vax people really are getting out of this whole thing, To be skeptical or to ask questions is one thing. You may want to know what are the side effects. That's perfectly legitimate to ask those questions. Will it cause this side effect or that? And yes, all vaccines will have some side effects. Nothing is ever 100% safe. Maybe 0.1, 0.01%, yes, there will be. What are those side effects we need to know? But then to put all vaccines, trash everything and say we should be liberated of vaccines, that's like, okay, let's go back to the Middle Ages when we would die of measles and pneumonia and everything. Let nature take its course. So in fact, to come back, antimicrobial resistance, that's the whole danger, that we'll go back to the time when nature takes its course and we are not able to cure people the way we are able to now.
So what doesn't kill them makes them stronger. That's Superbugs for you.
But then half are dead. So.
Yeah. No, I'm talking about Superbugs. So I can see a few more hands up, but we're really now short of time. I just want to thank wonderful panelists. I think we've had such a enriching, informative last 50 minutes that we really lost track of time. I think both of them will be around for some more time after this session. So please feel free, if it's okay, to walk up to them and ask your question. I think I just want to say that in this fight against Superbugs, in this fight against AMR, we all have to play our role. And that's also why our initiative is called Superheroes Against Superbugs, because we have to become superheroes to fight the Superbugs in our own way. And please stay informed about AMR, stay connected with all of us who've been working on AMR. If this is something that interests you, this is something that you want to now contribute to, and look forward to having you at our next events and other discussions that we have in the future. Thank you all for joining us today, and thank you once again to all of you.